It's now my pleasure to turn this morning's session back over to Junior Harewood, the Chief Executive Officer for New York of UnitedHealthCare. We're going to start our fireside chat on how racism affects healthcare. So with that, Junior, the floor is yours.
Okay, great. Well, thank you, Eric. It's a pleasure to introduce Professor Jamila Michener and be part of today's discussion. On the connection between racism and health outcomes and the importance of investing in efforts that advance racial equity and the role health plans, providers, and policymakers play in advancing a more equitable system. Professor Michener is an associate professor of government and public policy at Cornell University. Beginning in January 2024, she will be begin a new role as the inaugural director of Cornell's new Center for Racial Justice and Equitable Futures. Professor Michener studies poverty, racism, public policy, with a particular focus on health and housing. Many members of historically marginalized racial and ethnic groups have long experienced health disparities across a wide range of conditions and medical specialties. Ample evidence demonstrates that these people report worse experiences with care and receive lower quality hospital care, including more frequent readmissions and procedural complications. These disparities often result in inequitable access to healthcare, which persists because of the various factors, including structural racism in society and healthcare policy. So, Professor Michener, I'd like to get your perspectives. But before we jump into the discussion, just again as a reminder, to submit a question, please use the Ask a Question function on the conference app to get it going.
Yeah, that's fun.
High tech.
Yeah, I know.
All right.
Fancy.
I'm the last person that should be doing the high tech. So
we could barely get these air things
That's
on.
right. We were going with that for a little while there.
Yeah.
So we might have to go old school before this is out. All right. Let's start with a simple question, and hard at the same time. How do you define racism, and why is it important to consider racism as a set of processes that can lead to disparities?
Yeah, this is both a simple question in the sense that like a lot of the work I do focuses on it. So it's like, oh, of course I can answer it, but it's also hard because I'm like, well, I can write entire research articles on this and somehow I'll try to say it in 30 seconds. But one thing that I always think is important when it comes to defining and conceptualizing racism is to move away from what can be common, which is thinking about racism in terms of what is in people's hearts and minds, or in their heads. I mean, it's not to say that sometimes people have, discriminatory or racial ideas or feelings or sentiments in their hearts and minds. And that's, that can explain individual discriminatory behavior or individual prejudices, and those things are real, right? But racism is bigger than that. Some people call it like systemic or structural, and sometimes it's like, well, what are we really talking about? And then it starts to feel like it's everything, which is like, well, if it's everything, then I'm not sure I know what it is. But moving away from the kind of individual level, what's going on in someone's head and their heart and their mind, and thinking about systems and structures. And that might mean economic systems, it might mean political systems, it might mean social systems, or ideological systems, the way we as a society think about different groups of people. All of those systems interact together to create outcomes in life, in terms of income, in terms of poverty, in terms of health outcomes, and so on and so forth, that are differentiated across groups that we understand to be racial groups. And one of the things that I think is most important to understand the problem with those differentiations is that they don't have a basis in genetic or biological fact, right? So if you talk to a geneticist or you talk to somebody who studies the human genome, what those folks will tell you is that given genetic material or DNA, they can't tell you the race of this whomever this DNA belonged to versus whomever this DNA belonged to. It's not actually encoded genetically. It is a function of our social, political, and economic systems. So what we should see if we had no socially and economically inscribed racial differences, right? So if there were no racism. For any given outcome, like poverty, for example, it would just be randomly distributed across racial groups. Because there's no underlying biological or cultural reason for any other outcome besides that. But that's not what we see. Instead, for outcome after outcome after outcome, there are certain groups that we understand to be racial groups that are on the positive sides of those outcomes disproportionately, and other groups that are on the negative sides. Racism is just about understanding the processes that explain that, right? And how those processes emerge in our actual systems. So that's like the biggest view. And then of course, there's like lots of details under the hood.
Yes. All right. So the next question is, what is the role of cumulative disadvantage in racism?
Yeah, I mean, this is one one of the reasons why I wrote about this is because I would see this in class with my students, where students would say, well, the civil rights movement was like a lot of years ago now, and all of this time, to 18 to 22-year-olds at Cornell, something that was 50 plus years ago is like, oh my gosh, it's a whole lifetime ago, right? And they would say, it's been all this time, like, why do we still see these inequalities? We've had, at least in the law, we've had a legal requirement that we don't discriminate against particular groups of people for long enough that, like, shouldn't everything be evening out now? And one of the ways that I help my students to understand why racial differences, racial inequalities are very slow to yield to change. I mean, both because racial discrimination is still unfolding in many ways, right, and in many domains, but also because even if all racial discrimination, all racism had stopped in 1965 with the passage of the Civil Rights Act, it would take a long time for us to really see equitable outcomes at the other end. And the reason is because racism is cumulative. It's not just happening in one domain, it's happening in many domains. So I'll give you an example really quick. I do a lot of work on Medicaid, and I study Medicaid policy quite extensively. And so several years ago, when policymakers were, maybe more than several years ago, now it's like probably 10 years, I started to have these conversations with policymakers who were like, well, the way we're gonna get Medicaid expansion in our state is by attaching a work requirement to it. That's how we can get our legislature on board. And I would try to use this example of how that kind of leans into processes of cumulative disadvantage that are part and parcel of racism. So I'm a Medicaid beneficiary, and now whether or not I can get access to Medicaid is gonna depend on whether I can get a job. There are a few different things that means. We have substantial research, both contemporarily and historically, but some of this is contemporary, and the research is strong, that there's racial discrimination in the low-wage labor market, right? We've done all kinds of field experiments and also audit studies that show, all other things equal, it's gonna be harder to get a job as a low-wage worker if you're Black. And so now, if we attach a work requirement to your healthcare, your challenges with racism in the labor market are now spilling over and creating challenges with healthcare. And that's not all. We also know that employers, we have really strong evidence to suggest that employers use zip code as a way of determining which workers to hire. And they discriminate against workers from zip codes that they consider bad neighborhoods. Those are neighborhoods where Black and Latino Americans are disproportionately likely to live. Now, that neighborhood-based discrimination, which leads to weakness in the labor market, is now gonna affect healthcare. Similarly, with the criminal legal system, it's harder to get a job if you have a criminal record. We have all sorts of evidence of racial bias in the criminal legal system. So now, if we say you can't get your Medicaid unless you have a job, labor market bias, neighborhood bias, and criminal legal system bias all translate into bias in the healthcare, and that's cumulative disadvantage. So if we say, oh, we know, we're gonna go fix one of those, we're gonna fix this policy. Well, you still have all of these other domains, and they're self-reinforcing, and they've been affecting each other. It's like a snowball, and it starts to roll, and you can like pluck little pieces of snow out of the ball as it rolls to try to fix the problem, but it's growing, right? As it rolls and it's difficult to change. It doesn't mean it's impossible to change, but it means it's difficult to change, and it means you have to think about the systems and how they interact with each other. You can't think about it in a siloed way.
Yeah, it's important to kind of look at the kind of the global viewpoint rather than kind of just focusing on the one thing. All right, so why is it important to consider power relations when discussing racism?
Oh, yeah, so one of the things that, I'm a political scientist, so the short answer to this is that to a hammer, everything's a nail. And I'm a political scientist, so I tend to think power matters because we're trained to think about things in that way. But also, if we think about any status quo, and right now the status quo in the US with respect to health and many other areas, but even if we just focused on health, the status quo is one of really striking racial disparities. Everything from morbidity, mortality, to specific conditions, heart disease, cancer, so on and so forth, we see gaping chasms across racial groups that cannot be explained, like I said before, by genetic or cultural differences. So there's something about our systems that are creating these disparities, these outcomes. And we could just think about the disparities. Most of us look at disparities and we're like, that's bad. I'd like everybody to have a chance of having a good, healthy life. Most people hold and share that kind of value. And if you're in this room, I think you're even more likely than the average person to share that sort of value. I want everybody to be able to have equal access to a healthy life. But for whatever reason, that is not, despite that being a widely shared value, it is not what ends up happening. And we could think that's just by accident or it's incidental, but what's more likely is that our status quo benefits someone somewhere. And whomever is benefiting has the power to maintain the status quo. And unless we identify power relations and power dynamics, it's going to be hard to think about how to shift the status quo. I often think about, for example, Medicaid beneficiaries and the extent to which they have a voice, to which they have power. They're being affected by health systems, but often not a part of shaping the design and trajectory of those systems. And to think that we can change systems without including in the decision-making process the people who are most affected by those systems, most vulnerable to those systems, it doesn't even make logical sense. And it also doesn't bear out in the research record. Instead, when the people who are most affected by systems have power over the structure and design of those systems, what do we see? We see improvement in those systems. And so power is about thinking about who's affected and who has voice, who has a say in the decision-making process, not just who's at the table, but who can influence the decisions being made at the table. Now, it doesn't mean now Medicaid beneficiaries should make every decision. No. It just means of all the people who are stakeholders, we love that language of stakeholders, that among those stakeholders, a key group are the people who are being most affected by the systems and processes at issue.
Yeah. All right. We have our first question come in relative to that. So we'll, this is a tough one. All right.
Oh no, you're scaring me. I did a radio call-in show once. Nothing could be scarier.
Okay, yes. Oh my God.
And it was in Wisconsin.
I would never do that.
So any Wisconsinite can just call and ask me a question. I'll take this any day.
You're bold. All right. When you look at cumulative disadvantage, what do you think is the best way to begin to dismantle racism systemically? In other words, if you can't undo all systems at once, where's the most effective place to begin?
Yeah, that's a great question. And it is a hard question. And I guess I have two relatively quick answers. So the simple, practical answer is begin where you are. Because you're right, you can't undo every system at once, you can't change every system at once. But there are systems where we have more or less influence and power ourselves. So beginning by recognizing whatever system you're embedded in and whatever power you have within that system to alter it is a first step. And then I would say a second step is to start to think about how that system that you're embedded in and that you have power over is connected to other systems that perhaps you're not embedded in and perhaps you don't have as much power over. and start to imagine how you might build bridges between those systems, because that's what gets us to addressing sort of the cumulative elements of things. And that can be a little daunting. It can be like, you know, I am a healthcare person, and for the vast majority of my career, I focused mostly on healthcare. In the last several years, I started doing this work on housing, and sometimes when I'm at a conference with a bunch of housing people, I can feel a little bit like, oh no, these aren't my people. I don't even know what that just meant that they said, you know? But part of the reason why I pushed myself to bridge into another domain is precisely because the housing folks can't quite get it right if they're not understanding some of the health elements that are implicated in their work, and vice versa. So really, like, how can we stretch ourselves and stretch our boundaries so that we're both leveraging and maximizing the influence in the places that we have it, but also extending that to the extent that we can, which I acknowledge is a little bit less comfortable. And the second thing I'll quickly say is that this is why I focus on process, because it's going to be hard to change policy outcomes in every single domain. But if we can push to change processes in every domain, so for example, I was just talking about power. Now, it's going to be hard to say, like, okay, I know all of the policies that are going to make housing better. Maybe you don't. You're a healthcare person. You know, I don't know how to make the criminal legal system better. That's not what I do. But I know in every one of those systems, the people being most affected by the system having voice and power is going to make things better, right? And that if we socialize those kinds of process-oriented values into every system, that will build in the same way that disadvantage builds cumulatively, so does equity. And so how can we alter the processes in every system that we have any influence over so that they build towards equity instead of continuing to perpetuate inequities?
Yeah, yes. All right. All right, so how do you suggest that individual organizations, and I guess we touched on this to a degree already, I'll ask it anyway, and you can say, well, I just answered it.
You probably know this one better than I do, right?
All right, so we'll play back and forth on this one. How do you suggest that individual organizations go about addressing racism in healthcare? Put another way, how should institutions across the healthcare sector, health plans, hospitals, drug companies, physician practices, address racism in healthcare in a manner that goes beyond the role of clinical care?
Yeah, I think this is a good one, and I think it's a hard one. But I think it's good because it speaks to, like, all of you in the room, right? Yep. Like, okay, what do we actually do? And it speaks to the gap between sort of knowledge about these things, like, oh, okay, health disparities, I know they exist, I know they're bad, to action. And what I would say around, there are a few different pieces, but one thing I would say is it's not to be underestimated how important it is to simply continue having these issues before you and having them on the agenda and on the docket as something that is always being visited and revisited. We have this tendency, I think, and it's rightly so, because racism is a hard thing to talk about. You know, it's if you're a white person, it's uncomfortable because it's like, oh no, does this mean I'm a racist? Does that mean I'm a racist? Did I do something wrong? Am I going to get in trouble? Do I look bad? Oh my gosh, you know, shut off those voices in your head. And even as a person of color, as a black person, it's like, oh no, I'm like one of 4 black people in the room. Everyone's looking at me. Oh, are people going to think if I do something bad that makes all black people look back, oh no, I got to be perfect. I got a PhD, y'all. You know, like, shut those voices off too, yes. Right? But we all have different internal dialogues that make racism uncomfortable. So where inertia pushes us is towards, if you're well-meaning, you want to acknowledge it, but you sort of eventually want to stop talking about it so much. You know, students will say this, I teach this course on the politics of public policy. It's about public policy, it's not about racial inequality on its face, but we end up talking about it a lot because that's been a part of US public policy. And students will say, like, oh my gosh, it's so hard talking about this all the time. I'm like, yes, it is.
Yeah, yes.
Right? And then so A is like, keep going, right? Don't give in to the urge to avoid the hard stuff, because the problem remains and we can't stop addressing it. But then beyond like talking and beyond conversation, I think really looking at one's processes and systems, and I guess the processes and systems that you're embedded in, right? That can either make your life easier or harder that maybe you don't normally think of in terms of racism, but have implications in that sense, right? So one of the things I've talked to folks about is like, payment system reform. Like when I've gone to like conferences with like medical actuaries, and they're talking about payment systems from an actuarial standpoint, and there's no connection at all to any of this. And I'm like, well, do you know that the fact that Medicaid is reimbursed at a lower rate than private insurance or Medicare has racial justice implications? Because over 50% of Medicaid beneficiaries are people of color, whereas over 80% of Medicare beneficiaries are white. By saying we literally are going to price care differentially across these two groups, we're creating a basis for racial bias. So that as a Medicaid beneficiary, you go to the clinic and you see the sign, not accepting any Medicaid patients. And like, is that the doctor being racist? No, not necessarily. But it's built into the system that the doctor is not incentivized to treat patients that are disproportionately likely to be Black. Now, somebody somewhere in this room is thinking, what's our advocacy campaign gonna focus on? Like, where are we gonna lean in terms of the weight of our influence over these different systems? And I guess I would say a big step is really thinking in terms of what the implications are for racial disparities in your space, and not taking the status quo as it is for granted. And that's going to mean different things to different people in this room. But I think once you put those lenses on, there's going to be no shortage of opportunities.
I think you're right. I'm just having folks at the table and speaking to the issues that can help just inform.
Yeah.
Right. So I think that's critically important. And yes, as you diversify your, if you're talking about from a health plan perspective, you're diversifying your workforce, you're diversifying the physicians and the folks who are providing care. Those items start to come about.
Yeah, I love that you brought that up. That one's so important.
Yeah.
And as a researcher, some of these things we just have such strong data around, right? Decades of building an evidence infrastructure that tells us some of the different things we can do, and then we still like wring our hands, like, what can we do? What can we do? And often we know what to do, but it's really hard to do.
Really hard to do. No, you're absolutely right. All right. What are the major obstacles to achieving health equity and addressing racism in healthcare?
Yeah, I mean, some of these have come up. But I think in terms of major obstacles, I think I think our siloed nature is one major obstacle, and that reinforces the whole notion of the cumulative disadvantage. The fact that we tend to be thinking about things in our spaces and not always connecting it to other spaces means it's difficult to really get to the problems at their roots. I love whoever that, I forget his name, who was talking about the mom's meals. And the panel on social determinants of health, just because that starts to get us at some of the many areas that are integrated with health that really matter. And so I would say that is a big challenge, not just because we're siloed, but because it's like psychologically daunting. I'll have students that will say, oh my gosh, it feels like we need to fix everything in order to fix anything. And that you just freeze, Like the natural response to that is like absolute stasis, because I just don't know what to do. And I think that is a huge obstacle. I think pushing back against that and saying, okay, well, but I'm just gonna put the next foot in front of the other. I'm gonna figure out what steps I can take and take them. And the other obstacle is that, often, whenever I talk about voice and power, people are always like, yes, yes, bringing people to the table. Like, yes, everybody in theory, like, it's a great idea, But in practice, if you're at the table and you're a decision maker, the more additional people you bring to the table, the less power you have. Now somebody else's voice that may or may not coincide with what you think. Somebody might have another perspective, and it's like, oh wait, I gotta listen to somebody else. I have to be a little displaced to some extent, or I have to have less voice, less power, so that we can make space for more. And frankly, that is a barrier, both because most of us are not self-aware about our power. We're like, no, I don't have any power. It's like, okay. I had my students do this analysis of our local county. They did a power analysis of our county. They interviewed all of these health leaders in our county. And every health leader was like, oh, no, I don't have any power to do it. It's that person. And you talk to that person, I don't have any power. It's that person. Because we're so unaware of what power we do have. Never mind how to share it with others, how to extend its reach so that other people are incorporated. And until we get really savvy about that and really painfully honest about it, I think that will be an incredible barrier as far as really instituting change at the deepest levels.
Yeah, yes. So, so to kind of build on that a little bit, how important is buy-in from the top, and what does that look like?
Yeah, I think that's a great question. I mean, I think it's really important. And often what it looks like is people willing to make sacrifices and go out on a limb, because the status quo, the inertia doesn't push you to, I think, make the decisions that are going to lead towards the most transformative change. So I think leaders that are willing to disrupt and to produce discomfort, but to sort of push through it. And discomfort doesn't always have to divide, right? We can be uncomfortable and then figure out how to use that as an impetus to working together towards a different place. That's part of what transformation looks like. So I think leaders are important, but, and it feels wrong saying this to you, I'll end by saying, I don't think we should overemphasize leadership. Yeah. I think the best change processes tend to be processes that happen from the top down and the bottom up, right? And transformation comes when you get those, the confluence of the two. But just like a leader who really wants to push the boundaries can be displaced by their board of trustees or whomever, you know? But when you have the top down and the bottom up percolating at the same time, that's really difficult to stop.
Yeah. No, I agree with that. In business in general, it's a philosophy I've always had. I mean, the best ideas come from the folks who are closest to the situation and kind of working its way up and pushing it down sometimes.
Modeling good leadership.
I try. The inverted triangle, as they say in the org charts. Okay. All right. Are systemic issues that contribute to racism beyond the control of healthcare organizations? Are there strategies that could address those obstacles?
I do think it's fair to it's important to recognize that a lot is beyond your control, right? Not to sort of overestimate what you can do, both because that can sort of lead to a nihilism if you're like, we can change everything, and then you have this 10-year plan, and at the end of the 10 years, you haven't seen the degree of change you want. It may be because you overestimated how much you could change from as sort of within whatever sphere you're working in. So I think sort of, I am like not a business person, so I don't always use this language, but right-sizing our expectations, right? I always put that language in quotations because I'm like, what does it even mean? But I think you all know what it means. Right-sizing our expectations, and that doesn't mean not being ambitious. It doesn't mean taking real transformative change off the table, but it means understanding where our part ends and the part of others begins. And that means it might mean thinking about coalition, about collaboration, about recognizing our limits, not by capitulating to them, but by being responsive and adapting to them, right? Yeah. So I think that's really important.
Yes, yes. I recall, there was a time we did a tour around one of the states I was in beforehand with a bunch of healthcare providers, and we had all this great data. And UnitedHealth Group has tons of data. And we came in and we're like, all right, here are all the issues that are happening in your community. And they're like, not quite.
Wow.
Right? They took it a level deeper to kind of show that, and just to give an example, behavioral health, we said there's a tremendous amount of behavioral health providers. And they said, well, there's a tremendous amount, but most of them are not practicing.
Wow.
Like, oh, okay, that's a good piece of information to know. Yeah. How are we doing on time?
I think we might be up against it.
All right.
Maybe one more quick question. I certainly don't want to cut off the conversation. I think this is really a good foundational discussion for our lunch and keynote on diversity, equity, and inclusion. But I think we've got time for one more.
All right, so I'll end it with this one. How should the audience, those in attendance today, think about their own roles and accountability with their own organizations for creating a more inclusive healthcare system and addressing racism in healthcare?
I love that. I love that word accountability, which I think always sounds like a great idea when it's about someone else, Yes, we should hold them accountable. Oh, me? You mean me? No, thank you. my children are like this. One always wants to hold the other one accountable. I'm like, okay, let's talk about your accountability. And so I guess I would say, in line with what I said before, sort of really being honest about your own power, like what can you do? And are you doing what you can do? And are you working to expand the range of the things you can do? And often a good way to hold, for me, a good way I hold myself accountable is to ask myself, am I stopping as soon as it feels uncomfortable? Because it's not like I want to live in a state of constant discomfort, and nor do I encourage that for any of you. Stress is a determinant of health, so let's try not to maximize it. But at the same time, really asking if we're going against the grain of the status quo, because the status quo has gotten us to where we are now. And we can rail against racial disparities, but unless we're willing to really do something different, something that maybe sounds a little bit much, something that maybe feels a little uncomfortable within our organizations and beyond, without that, we're really not going to see the kind of transformative breakthroughs that we need if we want our children's world and our children's children's world to be different than now. I always say, I don't want my kids sitting on a panel 20 years from now talking about racial disparities. I just really don't. I want them talking about how we transformed racial disparities, right? And how they can do something else, whatever, save the planet in some other way. So the question is, how do we bring that future to fruition? And how do we identify and recognize the power each of us have to do that, and then move, work, do it?
Well, this is great.
Junior Professor Michener, thank you very much. This has been a great conversation. Please join me in thanking.